Welcome, everyone. Thanks so much for joining me tonight, and thanks to Therapro for having me chat about one of my most favorite topics, childhood apraxia of speech. I'm super excited to be here and to talk about this fun topic. So this is me. I'm Lisa Mitchell. I'm a pediatric speech-language pathologist, and I've been in the game now for about 20 years. In about 2008, I got very interested in learning more about childhood apraxia of speech, and I've been on that path ever since. So I am the co-owner and clinical director of Clearly Speaking, which is a private practice. We have 3 clinics located throughout New Hampshire. I've been recognized by Apraxia-Kids, formerly CASANA, for expertise in advanced training in CAS, and I'm New Hampshire licensed and ASHA certified SLP. I'd also like to add that in March, our company flipped to telepractice, and currently I'm treating 95% of my caseload remotely, and the majority of my patients do have some varying degree of CAS. So just to get these disclosures out of the way real quick, I am the co-owner of a private practice. I am receiving compensation for this webinar and have received compensation and royalties for webinars through Apraxia-Kids. Non-financial relationships, I am on the Apraxia-Kids Review Committee for intensive training candidates, and I'm an ASHA member and a New Hampshire licensed SLP. One last thing, I have loads of videos and photos in this presentation. Please refrain from taking any video or screenshots of this webinar, as the parents have given me permission to use their child's photos and videos for instructional purposes only. So my goals for you today are that we will explore critical thinking that we use to drive the choice of our therapy techniques. We'll increase our understanding of linking therapy materials to practice type of CAS. We'll increase our understanding of techniques and strategies for the treatment of CAS as we can see them used in action, and identify ways to promote generalization outside of the treatment room. My hopes for you are that we'll come away from this webinar with some ideas that you can put directly into practice. So I'm constantly learning, and these are both my teachers and my inspiration. I'm so impressed that anyone is online tonight after working today, especially if you've been online all day. But obviously, if you are here, you're looking to further help your kids. So I would like to cheers to that. So if you've got a cup of tea or a glass of wine, raise it in the air and let's cheers to these kiddos, right? Okay, so today we're going to look at functional treatment across a variety of considerations for CAS. We're going to identify ways in which we can provide treatment, and I'm going to try to give you examples for both in-person and telepractice, as I know many of us are using this medium. Just real quick, if we could get a poll. I'd love to know who is in the audience and type of what profession you belong to, and also your experience level in CAS.
It looks like about half our audience is identifying as a speech-language pathologist or speech-language pathologist assistant. We got some OTs and some parents and a few educators in the audience as well.
Fantastic. I'd also love to get an idea of the
All right, so it looks like about 39% are saying some, 41% are saying minimal, 16% are saying none, and 4% are saying extensive.
Okay, super. This helps me quite a bit. Today we're going to look at, like I said, a variety of considerations for CAS. We're going to spend some time looking at motor learning, prosody, vowels, choosing targets, and general tips for effective therapy. The theme that's woven throughout this webinar tonight is functional. And we're going to offer many ideas on how to make treatment functional. We want to make sure that our kids are going to use the targets that we choose. And so much thought comes from us as SLPs on how best to choose our targets and how to structure treatment. So the dictionary says functional is having or serving a utilitarian purpose. So we are really looking at the usefulness of the treatment we are providing these kiddos. All right, so we are going to touch on motor learning, and I'd really like to emphasize the word touch on. Motor learning is a really broad topic, and we're really not going to get deep into it, but I'll share some resources if motor learning is new to you. So if you want to do some digging on your own time, they'll be there for you. So CAS treatment is different. It's different than the traditional treatment for speech sound disorders. When we provide treatment to kids with CAS, we're using the principles of motor learning. We're focusing on a movement gesture versus a sound. So if this in itself is new to you and you're new to treating CAS or haven't to date like a few of you, I really urge you to read ASH's 2007 technical report on CAS or visit ASH's practice portal. And most definitely the 2008 Principles of Motor Learning and Treatment of Motor Speech Disorders article by Mass et al. So keep in mind that for motor learning to occur, a child needs to demonstrate motivation, focus practice, and have an understanding of why we are practicing certain movements. So if you have a child that lacks any of these, this is likely where you're going to start your treatment. Think of this as we're maximizing readiness for treatment. So how do we do that? Well, we can bolster these precursors by doing a variety of different things. So we want to increase the child's ability to imitate. So we want to move from gross motor imitation to fine motor, which we know speech is. We want to establish trust. We want to have the child be able to attend to the clinician's face, have a production of a variety of vowels, get the child to tolerate tactile and verbal feedback, identify what motivates the child, and certainly limit extraneous stimuli in the treatment environment. So if we start with how we build imitation in kids, we can certainly teach early imitation by using gross motor imitation to set the stage. We need to understand that do what I do is the foundation of CAS treatment. So ultimately our goal here is bringing awareness to movement. So in this slide, I have a picture of a page from a book by Eric Hall called From Head to Toe, which I'm sure many of you are familiar with. And in this picture, there's a buffalo raising his shoulders, and it says, I'm a buffalo, I can raise my shoulders. Can you do it? I do like to change the verbiage to you can do it to instill that growth mindset in our kiddos, but essentially you just want these kids to copy your motor movement. There are so many different ways you can get kids to practice imitation. I have a bunch for you here. I'm sure many of you are familiar with Kid Boomers, so you can play the freeze dance, which you get off YouTube. You can essentially just do any kind of body warm-up where you're using big movements and then getting towards smaller movements. If you're familiar with boom cards on Boom Learning, we'll talk about this a little later, but there's motor imitation on boom cards that someone's made. That's free shareware. That's really great. Certainly you could use the song Head, Shoulders, Knees, and Toes, again on YouTube. The one that I like is by Simple Songs, I believe. Just keep in mind if you're working with a child with childhood apraxia speech and they have full body dyspraxia, coordinating and sequencing the motor movement for head and then shoulders, knees, and toes might be too much of a challenge. So keep that in mind. If you're familiar with the Laurie Berkner Band, there's a song called We Are the Dinosaurs where kiddos imitate dinosaur movements. And another Kid Boomers good one is Walking, Walking, Hop, Hop, Hop. So there's links for these if you haven't heard of any of them, but these are great ways to get kids to imitate. I've been using a lot of these since I've been doing telepractice. So one way to bolster a precursor is to work on motivation. We know as speech pathologists that motivation is essential if you want to be successful in your treatment. We know that we have to be flexible to figure out what motivates our kids and really keep an open mind. What's really most important is that we get information from the family and we don't assume we are going to know what motivates our kids. Another way to increase motivation is when you're in therapy is to give the child an opportunity to switch roles and be the teacher. You'll see me do that in a video clip later on tonight. So a great way to get information about your child from the family is to use this functional communication questionnaire. This is by Wilson and Gildersleeve Newman. It's free online. There's a link here where you can get it. And this is a really thorough questionnaire for parents to fill out information on their children. You learn about important names in the child's life, activities they like, all sorts of things that you wouldn't readily know about a patient. So this is something I hold dear in my treatment, I put in my file, and I refer to it quite often. So again, it's really important not to assume that you know what's going to be motivating to the child, but you really dig a little deeper and you find out. So here is just an example. I have some motivators here. So the picture on the left is a kiddo of mine who was really into Simon for, it feels like months. And he wore these Simon glasses. We used Simon books. I made Simon activities, and he was super psyched to come to treatment and really motivated during these days of Simon. So I milked it for everything it was worth. And then if you see this little picture of the guy on the right-hand side, he was all about things boo-boo related. So I pulled everything I possibly had on boo-boos. And he was super motivated to practice his speech sounds. I believe that game that he's using is called Howie's Owie. I don't know if you guys are familiar with that, but it's a commercial toy. And then this guy in the middle, his name is Puppy, and he is one of my current patients' favorite stuffed animals. And so I decided to bring this inanimate object to life using an app called Chatterpix. I've seen a lot of social media where other speech pathologists are using Chatterpix or like apps where they're bringing inanimate objects to life. So I gave it a go, and I used a very small clip at the first time I used it because I didn't know if bringing his favorite animal to life was going to scare him to death or not. So I actually will play the little video for you. I have. So give me a second. I'm going to play this video. I just brought this puppy to life. My little guy absolutely loved it, and now Puppy is embedded in a lot of our PowerPoints. We're doing only telepractice, so he never knows when Puppy's going to show up, and he's extremely motivated to see when he'll show up again in our therapy session. So this one has been a huge success, and I've been using it quite often. So another way we can increase motivation is we can change a child's body position. So when we're having them produce their targets, you can have them at the table, you can have them on the floor, you can have them sitting down, standing up, standing on one foot, standing on their tiptoes. I've been using this also a lot in telepractice, and it gets kids re-engaged as well as motivated. Okay, so another precursor we want to build is establishing trust. And one way to do this is we can minimize the pressure we're putting on these kids. So these kids have likely had many failed attempts at communication. And so having early success with your patient is really going to lead to trust. So one way we can do this is we can minimize the pressure by deflecting attention to a third party. So I'm going to show you a video clip of my buddy Jackson here, who has brought his pet dinosaur to therapy on this given day. And we use this opportunity to deflect attention to the dinosaur and take the attention off of him. And just for reference, This child also, he has a dual diagnosis of CAS and ASD. So optimal challenge point. This is another way we can facilitate motor learning and minimize any kind of pressure. So we want to work at a level that's optimally challenging. So we could choose words that motivate the child and have significance in their life, which we talked about with the functional communication questionnaire. Choose sounds from the child's phonetic inventory and target sounds and phonotactic structures where the child begins to break down. What you're looking to do is you're looking to, in the early stages, create low frustration. In the later stages you can be a little bit higher as you want them to learn from their errors. So essentially you want to find the sweet spot. You want to be between high difficulty but stay high in successful practice to have optimal motor learning. Okay, so we're going to talk about feedback, which is a principle of motor learning. And with our kids with CAS, they need two different types of feedback. They need knowledge of results and they need knowledge of performance. When we talk about knowledge of results, this is telling the child whether their production is right or wrong. When we're talking about knowledge of performance, we're talking about what needs to be done to improve our target productions. Our kids with CAS need both type of feedback. When you're in early stages of learning, you're going to require feedback on performance. This is where your instruction happens. And as kids get better with the motor plan, your feedback is going to be more related to their results. So some examples of knowledge of performance are things like you need to make your lips round, open your mouth a little wider, put your tongue up like me. And then if we're talking about knowledge of results, we're talking about things like, that's it, yes, when they're correct, or not quite, or different if they're incorrect. Okay, let's talk about massed practice. So motor performance improves when we give the child an increased number of practice trials. So consider every time that you elicit a production, try to go for a minimum of 5. So we know that mass practice allows for acquisition of targets. But keep in mind when you're going for these high number of targets that you're having a child produce good productions with articulatory accuracy, because we know if we practice something with repetition that is poor in quality, then we're going to get something poor in quality that's going to stick. So we have a saying with kids with CAS, and that's practice makes permanent. So you want to be careful of the motor plan that you're laying because that's the motor plan that's going to stick. So there are really endless ways to get multiple trials. We can certainly use repetitive books. We can use books with repetitive images because we can count essentially with labels. So instead of counting with numbers, 1, 2, 3, 4, 5, essentially we're just labeling what we see. So we can get a lot of repetition of the image that's depicted in the book. So I'm a little nervous, but I'm going to try to play another video here of me doing this in action. So let's check it out here. Okay, so you can get the picture where you can use a book with multiple images to get repetitive practice that way. So when we use, when we're going for repetitive practice, we can also go for using repetitive books which we as speech pathologists are very used to using. We use repetitive books as closed tasks. So you're having a child just fill in a word in a repetitive line. So we're very used to using books like Brown Bear. So with a child with CAS, maybe our target might be me, but as we increase in complexity, maybe we're changing it to at me and then maybe looking at me. So over time, we're building the complexity of what we're looking for. Or we can use a you know, another familiar book like Polar Bear, maybe your first target is ear, and then my ear, and then maybe in my ear. So some of my other favorites are Pete the Cat, rocking in my school shoes, where your targets might be shoes or no. Go to Sleep in Your Own Bed by Fleming and Nichols, and maybe your targets are up and bed, or Hooray for Hat by Juan, and maybe your targets are hat and away. I'm hoping everyone is seeing my screen. There's also a book series called First Sound Series by Pereira and Solomon, and these two have great opportunities for repetitive productions. There are so many different ways to create opportunities with kids for multiple trials. So things like putting coins in a jar. You can use different denominations, like the higher number is better, obviously, for our intents and purposes, but using dimes and nickels, you can go for 10 and 25 repetitions at a time, and maybe your kids can cash their money in for a prize from the clinic at the end, or maybe you can have your kids earn play money. We're certainly familiar as speech pathologists with games such as Pop-Up Pirate. So anytime you have a game that has repetitive actions, these are great for repeated trials. We can have kids use stickers and stamps to build scenes. Certainly setting up and breaking down games you can use for repetitive practice. So the picture in the corner of this slide is that game Kerplunk. So you can get multiple trials even when you're setting up this game as you're sliding sticks in. So instead of wasting time with the setup or breakdown, you can actually be getting trials during setup and breakdown. Certainly using dice games. I have this die I got from the dollar store a million years ago that's oversized, and it's been great in telepractice, but I like to cover up the lower numbers like 1, 2, and 3 with like 5, 4, 5, and 6, so I can get multiple repetitions for my kids. Certainly using an abacus, kids can choose a color and they can, you know, get multiple trials for each bead. And then just the idea of building. So most kids love to build, so they can earn blocks or pieces to then build whatever they're looking to build. So I have been doing, like I said, telepractice since March. So I've had to come up with some ideas on how to do mass practice through telepractice. So if we could just get a quick poll of how many people are currently doing telepractice or in person, or maybe a little bit of both.
It looks like about 48% of our audience is doing both. 22% are staying in person, 20% are staying virtually, and 10% are staying non-applicable.
Okay, so super helpful. A lot of us are doing telepractice, so hopefully you can put these ideas right into use. So there are some tele options. So there are online abacus at this link I provided for you right here. And they, at the same website, they also have marbles in a jar. So these are great ways to get repetitive practice. A lot of those repetitive stories that I mentioned on the previous slide are available via YouTube, which are great to use over telepractice. Getting 5 to 10 productions to open a present, open a door, dress a character, using different games on the Boom Learning website are great ways to get repetitive practice. Like I said, building things are really fun. So you're essentially earning pieces by saying multiple targets. So building a monster or creating a car have been big hits. Creating online spinners so you can spin for repetitions, and they have spinners online that you can customize that have been really helpful. And then at our clinic, we happen to use lesson picks quite a lot. And I have examples of some things I've made using lesson pick software. So they are just like an annual subscription of software that you can use to make customized boards and games for your kids, which has been super helpful. And you can download them in PowerPoint format, use them as PDFs so you can draw on them and things like that. So this is an example of a game that I made really recently. I was practicing CVC word productions with initial W. And essentially with this game, I shared my screen and I asked the parent to bring a die prior to therapy, and I had one as well. And we would roll and we would say the target 5 to 10 times, and we would cross it out in our color because we could write on it because it was I used a PDF, and whoever got rid of their words first was the winner. So this went over pretty well. Kids really seemed to like this. I made this with lesson picks, like I said. This is a game board that I customized for one of my kiddos. This is, again, as a lesson picks game board. I made it for a child with CAS who was targeting CVC and CV word shapes for the vowel I. I used a modified block schedule in which I practiced a word with repetition. When a child landed on it, it was in a block of targets. I think there are 7 targets here. And then, so the child couldn't anticipate what was coming next, the next block of targets was randomized. Okay, we're going to talk about distributed practice, which is another principle of motor learning practice condition. When we talk about distributed practice, we're talking about rest periods that are inserted between practice trials or blocks of trials. So one way we can do this is we can have kids go on hunts. I'm sure you have had your patients or students gone on hunts before, but there's a picture at the bottom of a treasure map I had made with actually that same software, that lesson pick software. If you're doing telepractice, you can get a map to the parents prior to your session so they have it ready. And obviously your target words, you want to send them to them as well because they can put around the house. Or if you're seeing a child in person, you can certainly put them around your therapy room. And let me correct myself, don't put your targets around the house. Put them in the room you're working in. I've had some parents get really creative about where they want to hide pictures, and I have to let them know we don't want to make it too difficult, otherwise we lose the kiddo. But essentially, you're getting your child to follow the map. You can get them to distribute their practice because they're moving from one word to the next that has their target. And you can really modify this lessons to use to serve whatever stage of CAS practice you're in. You can do mass practice this way, obviously distributed, or randomize things pretty easily. All right, I'm going to try to show you another video here of one of my child's hunting for Z pivot syllables. So the Z pivot syllable is the second syllable of the word, which stays constant. So all the words have Z in the second syllable. And you should know, just for reference, that my friend in this video also has a unilateral hearing loss. He has an ear abnormality, and he wears a Baha. So let's see if we can show this for you. So essentially, it's just a video of a clinical treatment room. There are pictures hidden all around the room. The child follows the map, which was on my treatment table, and he walks around and hunts for the videos. You can also do distributed practice where you use containers. So any container you might have at your office or clinic is great to put your target in. So once you have a solid target, you can move to a solid carrier. So by placing objects or picture communication symbols in a container like eggs or trash cans or little presents, you can have a child request by color, size, and practice targets inside. So any kind of containers you can find are really fun. Anything kids can open, and then they can put their targets in phrases like I got, I see, or I found. So if you're in a school and you have access to a SmartBoard, this is a Valentine's activity that was made by a colleague of mine, where On the screen, you'll see all the targets of the child, and the child would drag one of the words into the heart, and he was essentially randomizing his own practice, which is a great way to practice distributed practice in a school setting if you have access to a SmartBoard. Another way to distribute practice, and this is great for home carryover and generalization of targets, is creating personal vocabulary books. So this is something I do very early on in treatment. I ask if the family can invest in a really inexpensive photo book, kind of like one of those grandma brag books that you could get at the dollar store that just has those clear sheets in it. And what I do is I send home successful targets by putting them in this book. And over time, they end up with a book of words that they are really successful saying. And if, you know, historically, these become pretty important to a child. The parent and the child decorate the book when they first create it, and it's something that becomes pretty special. I wanted to share that these vocabulary books are not beautiful nor creative in the sense where they really are just home practice. So the picture on the left is a target I forgot, and it was something we realized in therapy that the child was having success with. So I just drew it for him and put it in his book, and he was having enough success to carry it over. So I wanted it to go home for home practice. So some of these things happen in the moment, and you can still add it to the book like I did in this situation. But other times you can paste pictures in there from words you may have cut out and used in therapy. But I do urge you, as you see in this picture on the right, is that if there is a word like me, and you can actually use a picture of the child, that makes a lot more sense than using some cutout of, you know, a picture communication that says me and it's a stick figure of some sort. So anytime you can get a real photo, if there's a target like mom, put a picture of mom in there and things like that, because we want to make it as functional and as realistic as possible. Okay, so we're gonna move along and we're gonna talk about treating prosody with these guys. And we know that kids with CAS have deviant prosody. We're likely to see choppy, excessive equal stress, reduced loudness, variable resonance. We see inconsistent hypernasality quite a bit, and variable rate. So one way we can work on intonation is we can bootstrap speech productions based on neural mechanisms using melodic productions. So one way you can do this is you can search for targets around the room. So essentially you can call for the target using melodic production. I do have a video of this. I'm going to explain it on the chance that I can't get it to play. But in this video, there's a little guy who we were reading a book about a puppy. The target is puppy. And we would call for him around the room. So I would change my intonation, puppy, just trying to get the kid to imitate my change in intonation. So I'm going to give it a whirl, see if we can. So here is my little guy. So we were reading a book about puppy, like I said, and flipping through the pages, and he's just calling for him over and over again. And his grandma in the back there was just so proud of his hard work, as you can see. Another way to work on prosody is to work on sentential stress. So we can work on sentential stress by altering our WH questions, and having the child change their, make an accurate response by changing the stressed word. So let me show you what this looks like. This is my friend Haley. Okay. All right. So another principle of motor learning is constant versus variable. And we want to weave variability into our target productions. So we're changing prosodic features by having the child produce the target in different ways. So we're having a child produce their target maybe like a baby, or like they're angry or loud, or like Cookie Monster. And what we're doing is we're creating flexibility in their motor plan. This is really fun to work on. Kids usually love working on variability. So on the left-hand side are eggs with emotions. And one way to work on variability is if you were to put your target inside one of these eggs, the child could produce the target and then try to say it and match the emotion that's on the egg, which is a fun activity. And then on the right, this is a prosody wheel that I made a really long time ago. And essentially what the child does is they spin the wheel, and then we're asking them to produce the target like the picture. So in this prosody wheel, I have slow like a snail, like Cookie Monster, angry, loud, quiet with a high pitch, fast, or like a robot. And believe me, if a child lands on like a robot and they have apraxia, they're psyched, because talking like a robot would be quite easy for them. Okay, so I have another video. This is Peter. So a disclaimer about Peter. My goal here in this video clip is to get Peter to produce a CCVC word shape and increase his vocal loudness. My disclaimer is that Peter has a lisp, which in this moment I used my clinical judgment and I did not address. This is not an example of practicing perfect. Just to put that out here. So let me share this video with you. Point here. Okay, so keeping on with prosody, we can work on pacing. And one way to do this is considering to use signed English as a pacing cue, or to mark functor words in a sentence. So even though we don't typically prioritize a functor word with our kids with CAS, it's really important to mark them as we work through longer sentences. So there is a video clip of me using this later on that you can take a peek, but essentially marking words in sentences is a great way to help kids with pacing with CAS. So in terms of Tele options for prosody, I've come across a few so far. Many of you might be familiar with the Coo Coo Kangaroo Milkshake song, and the picture of on the slide is of this song. This would be more appropriate for maybe a child with more mild CAS, but it's a song where they produce the same verse, but they do it with varied suprasegmentals. So it's really fun, but a little more complex. You can create an online prosody wheel. So like the one I showed you that I made, I was able to make a virtual one that I'll show you a picture of. There's a website where I was able to customize my own wheel that I included here. And then I found a really cool, it's a magic mirror where you click on the mirror and out comes a picture of someone, and you can have the child create variability to match the picture they see. So let me show you a picture of these. So on the left, you have a prosody wheel. So the child spins and it lands on one of these things. I'm having them say their target in a certain way. So this wheel has like a monster, like Cookie Monster, slow, quiet, loud, or fast. And then on the right, I have a picture of the magic mirror that I use. So if you were to click on this magic mirror, a face is going to show up, or picture, and that's how I'm having the child produce their target. So we're weaving this variability and using this prosody wheel and this magic mirror, which has been really fun for the kids. Okay, moving right along, let's talk about vowels. All right, so we know that vowel distortions are characteristic of CAS, so that's why we're talking about them today. We want to start on vowels early. So what we're trying to do here is we're trying to increase the range, we're trying to reduce the deviations, we're considering using facilitative context of homorganic productions to aid in vowel production. So what that means is you're using a vowel and a consonant made in the same part of their mouth So the child doesn't have to move their articulators very much to have success. So their mouth is staying in the same spot. So let's say our target is the vowel E. We're going to choose a sound made in the front of the mouth. So maybe we'd use B. Say our target is O. We're going to pair it with a back consonant like G, and maybe our target is go. So another way we could target vowels is to use a vowel contrast. So in this picture, my friend Haley has the words bit, bat, and bet. So they only differ by the vowel, and she's working on changing her productions. I do have a video of this one, but I'm going to pass because it's the third in line, and I think it might get stuck. But she's practicing her just changing the vowel as the words are essentially minimal pairs. So vowels are considered the core of the syllable nucleus of a word, or I love it, the heart of a syllable, because they carry a lot of weight in regards to intelligibility. So this is why it's so important to target vowels. Like I said before, children with CAS demonstrate vowel distortions. So if you're unsure of what the child is producing when it comes to a vowel, if you're having a hard time transcribing it, it's likely a distortion. But keep in mind that a child will be better understood if they have if they have consonant substitutions or distortions, but have a correct vowel. So another thing you want to do is you want to consider targeting the cornerstones of the vowel quadrilateral. So if you haven't seen this vowel quadrilateral since graduate school, you might want to whip it out. But you're going to target here the cornerstones. So E, U, and Ah. So these are the highest, the lowest, the most posterior, and anterior portions of the quadrilateral. So you can target U, Ah, E as exclamations. Because in English they have functional value, but you want to quickly put them in a syllable because remember here that our goal is movement. Okay, let's talk about target selection.
Okay, so one question that came in is, can you explain the rule of 5 again?
Yeah, you bet. So the rule of 5 is, let's say you have a target going into therapy. When you elicit a production, instead of just getting one at a time, think of every time you're trying to elicit a production, you're going for a minimum of 5, because our goal is a really high number of repetitions, because we know kids with CAS need a lot of practice. So you want a lot of repetitions within your therapy session. So a minimum of 5 every time you elicit will keep your numbers higher than trying to elicit just one at a time.
Okay, great. Another question that's come in is, how many targets do you have per session, and when do you move on from a target?
Such a great question. So the more severe the child is, or the more severe the CAS is, excuse me, you're going to use a lower number of targets. So we typically recommend 5. But keep in mind that if you use less than 5, you could really overgeneralize a motor plan, and then that can really hinder your treatment. So you want to stick with 5 at the lowest number, and then certainly if a child can tolerate more, you're going to do more. Your question about when to move on is a really good one. I would lead you towards reading more about the principles of motor learning, because you want to practice your targets in mass practice, and then you want to move on to distributed practice. So there are some guidelines there that will help you in terms of how to organize your practice. And you'd also learn more about how to block and randomize once a child gets pretty accurate.
Okay, great. Another question that's come in is, how long of a duration we need to teach them for vowels daily?
Oh, good question. Well, depending on the severity of their vowels, if vowels are distorted, I always try to make them a part of my therapy session, and certainly a goal for the child. It really depends what your child can tolerate, but you can always start on vowels early because you really want to increase the number of vowels that kids are producing early on, because like we know, like I mentioned earlier, they have a lot of impact on intelligibility. So making it, if vowels are an issue, making them part of every session is great. I would probably start there.
Okay, and the last question for now, when would you suggest a child's parent investigate evaluations or therapy outside of the school setting? I'm concerned the school time will not be enough for one of my students, but I feel it is unethical to take him out of more academic hours at this time as he receives multiple services.
Oh, you bring up such a great point. I think you have already identified it's the right time because you're noticing that the child can benefit from more therapy, and it's looking like it's not going to happen within the walls of the school. So I love to collaborate with the school speech pathologist. I have a lot of shared patients on my caseload right now, and it's a wonderful opportunity to target things in different ways. And so you're still part of the team, even though you may not be the person doing the individual apraxia treatment in a school. But I think right now is the time because you've already identified they can use it.
Great, and we'll do another question and answer at the end of the webinar.
All right, super, great questions, great questions. Okay, so let's talk about target selection. So I love this quote. Choosing intervention targets and strategies that match the child's state of readiness and learning profile is one of the most crucial and difficult tasks that face the SLP. This could not be more true with our kids with CAS. And this is really a tricky kind of, it's a tricky slippery slope for us. We have to do a lot of investigating to choose the right targets. So when we think of choosing targets, we want to increase phonetic inventory. So this is where we want to establish new consonants that the child doesn't have, new vowels that they don't have, and word shapes that they don't have. We want to expand their use of place, expand their manner, or both. And we want to use sounds they have in more complex word shapes. And we want to add new word shapes by using sounds they already have. We also want to decrease their errors, so decrease their consonant errors, decrease their vowel errors, and decrease their word shape errors. And we want to improve suprasegmentals. That's it. That's all we have to do. So we really want to remember we really want to consider social language when we choose targets because we want these kids to use the targets we teach them right away. So if you have a little guy that doesn't have a whole lot of speech, teaching them things like, uh-oh, oh no, oh man, yeehaw, woohoo, yay, whoa, ta-da, are words that they're going to use, they're going to want to use, and they can use in a variety of situations. So really consider the social piece when you're choosing targets. This book that this little guy is holding is called The Big Book of Exclamations, and it's not a book with words per se, it's just a book where a child can use exclamations throughout the whole book, which is a great way to get kids to engage in literature early on. So also when we're choosing targets, we want to think about homorganicity. So we want to choose targets that are homorganic in structure to minimize the motor load. So this is what I was talking about with the vowels earlier. So we want to use facilitating contexts for consonants. So we want to pair an alveolar, so a t, d, n, with a high vowel. We want to pair a velar k, g, with a high back vowel, and we want to pair a labial, so those sounds made with your lips, p, p, with low central vowels. And this minimizes the motor load, so kids can get successful because there's less stress on their motor system. So if you're like, oh my gosh, I have no idea where the vowels are in the mouth anymore because I haven't looked at a vowel quadrilateral in a really long time, I urge you to just get it out. And it's really fun to create words. So when you're looking at the vowel chart, you can use it for reference to choose your homorganic targets. So remember, like I talked about with that questionnaire early on, we want to use targets that are unique to the child. So family members' names are super important. A child's own name is very important. And social considerations are especially imperative when kids are really shy or they're frustrated or they're exhibiting unwanted behaviors. I try to give my kids the answer to the two questions I feel like are asked most of kids, and that's what's your name? So I always try to get them to be able to at least have an approximation of their name, and then the ability to answer how old are you, which are two questions that I feel are asked of kids all the time. So I do have a video that I will try to play. This is my friend Jackson, and his speech was really not at the level where he had a complex word like the word Jackson. So this was really above his level of functioning, but it had such important value because it's his name that we did a lot of mass practice with this. I had to give him a lot of cues, but he was so motivated and got really excited about it. So let me just show you a quick clip of him practicing his name. Okay, so in that last video, Connor had very few functional words, but hi was one of them and mom was another. And the speech pathologist worked really hard to get him to use the phrase hi mom. And mom burst into tears after that was videoed. But that's a great example of choosing functional speech targets for kiddos. Okay, we're going to get into some general tips and time savers for effective therapy. And we're going to just move and cruise right along here. Okay, so make sure you're using a research-based approach when you're treating CAS. And currently there are few approaches that are supported by research evidence. Those include DTTC, REST, biofeedback, PROMPT, the Nuffield program, and integrated phonological awareness intervention. DTTC has the most research backing this approach. The approach focuses on dynamic movement, and your cueing constantly changes to support the level of performance. DTTC is based on integral stimulation, which was a treatment or is a treatment method used with adults with apraxia of speech. I have a video of myself doing DTTC with a little girl from my practice. So let me show you what this looks like in action. Okay, so whatever approach you choose, just make sure you have the right ingredients. So you want a high number of practice. You want a small set of treatment targets, certainly if the child is more severe. You want to make sure you have a homework component. You want to make sure you're using both knowledge of results and knowledge of performance feedback, and you're using alternative feedback modalities. When we're taking data on kids with CAS, consider using cumulative data. It's difficult to take data when using approaches like DTTC. So if you use a probe and maybe you get 20 trials at the end of a session, you can take data on that. And if you look at it cumulatively over time, if you look at this example, in sessions 4, 5, and 6, this child got 8 out of 10. But still looking at 8 sessions total, she's only 47% accurate. So you're looking at cumulative accuracy. You're adding up accuracy over a period of time. And this allows kids, you essentially buy them time to learn a motor plan. So I like to use cumulative accuracy versus traditional data collection with my kids with CAS. Think about leaning on your colleagues and using a community of practice. So certainly save time by using shared resources. Right now, I feel like with this telepractice boom, no pun intended, we're using Boom Learning, which is, check that out if you haven't seen that yet online. Certainly teachers pay teachers. We're using listservs. and certainly leaning on professional groups. Okay, one thing you can do when you're treating your kids with CAS is you can teach them to use a starter position. So essentially you're having a child hold a position to create awareness of where their articulators need to be to start a production. So I like to teach starter positions like for the bilabials where your lips are together. So I'll teach the position and then I'll have the child get in their position if I want them to say a word that starts with a bilabial, or an E position for a word that starts with ya, or an U position to start a word that starts with W. And this sets your child up for success because you're getting them in the correct position before they even start the word. So this right here is an example of an position. So you teach the position and then you can just name it. You tell your child get in the position, and then you could have them produce a word that starts with a bilabial. Landing positions are also something to rely on. We know that children with speech sound disorders may be less able to successfully use feedback that's typically available. So if you name positions and provide visual and tactile feedback to aid the child in producing a target with accuracy. So if a child was supposed to land in a nasal, I might say something like land in your nose. And I might touch the side of my nose. I'm giving them cues as to where I want them to land, just like I did with when I wanted them in a starter position. For the sake of having to sit through the other video that I showed you, I'm going to skip this one, but this was just my friend Jackson, who I was using the landing position cue because he was having nasal confusion and he was landing on his lips versus his nose when it was a word that ended with N, excuse me. So with the information that we have to date, oral motor exercises are just not appropriate for our kids with CAS. We know that motor control for speech is distinct from motor non-speech behaviors. So with the information we have now, if you were going to blow bubbles or blow horns or blow cotton balls across a table in therapy, then you're going to improve blowing bubbles and horns and blowing cotton balls across the table. So we don't want to teach those to our kids with CAS, or we certainly don't want to teach those if we think that is going to improve their speech, because with the information we have now, it certainly would not. But keep in mind that a placement cue is not the same as an oral motor exercise. And we provide placement cues to help kids get into correct positions. So we want to create opportunities to have the child to get into a certain position. So for example, if you were going to teach a retroflex R, you may use a toothet to help their tongue get in position, but you're quickly going to remove that tool and you're going to have the child produce the sound. So different than an oral motor exercise. Placement cue just gets the child into the correct position. Motor movement, you can practice motor movement with your targets. So sometimes speech is easier when you're moving your body along with your mouth. So think about putting a hopscotch board taped to your floor, and you can hop into your targets, or moving in and out of a hula hoop, or maybe moving a frog from lily pad to lily pad as you're saying targets. A lot of our kids with CAS, if they have certainly a severe form of CAS, they're going to need some sort of AAC. I use AAC throughout my treatment. By utilizing AAC, we're providing a meaningful framework for learning sounds and syllables and words. And certainly we're also supporting a child's overall speech and language development. So AAC can range from topic boards, sentence strips, to a device for those that are less verbal. But we want to provide access to AAC to certainly all those children who are minimally verbal. So here's an example. My friend Jackson on the left is putting his CV words in the sentence strip on the table that says I made as he put these puzzle pieces together. And then my friend on the right, she's using her device to engage with her classmates to talk about what she did over the weekend. You can use adjacency to facilitate production of elements in new positions. So let's say a child is successful in producing S final in a CVC word shape. You can use that to facilitate S initial by using S final. So if, let's say, they could say the word bus and that S is intact, you can pair it with an S initial to set them up for success. Group work is doable. So if you're in a school setting, group work is doable for our kids with CAS. Think about putting groups together, maybe in stations. Maybe they're doing the same activity. Maybe they have the same speech motor target, or maybe you're just doing natural groups that happen in school. But keep in mind it can happen, and use your paraprofessionals to help you in this process, because we certainly need to lean on our help in school settings when we're working with more than one student. We want to avoid negative learning as much as we can. So we want to practice errorless productions as much as we can. So when we're certainly at a place where a child is trying to acquire a new motor plan, we want to have them practicing perfect, because practice makes permanent. And if you don't transcribe and you're working with kids with CAS, I really urge you to start. If you can't read that top line, maybe you should refresh yourself with your old phonetics book, but it says dust off your transcription skills. So, you know, when I assess my kids with CAS, oftentimes they fall below the lowest standard score on a standardized test. And 6 months later, when I know they've made progress, they still might be demonstrating lower than the lowest standard score. So it looks, if you were looking at standardized tests, they haven't made any progress. So because I know that, and I know these kids are making progress, but maybe, you know, insurance is, you know, demanding that we provide a standardized assessment. I use other measures like percent vowels correct and percent consonant corrects, or the index of phonetic complexity, to show change. And the way to do that, you really need to be transcribing what your kids are saying and to show the change. And like I mentioned before with the question of the school SLP, it's really important to collaborate. I try to collaborate when I know someone else is working with my student. I try to collaborate from the get-go. It's really fun to figure out ways to work on targets within your different settings. And certainly the person that benefits the most is the child. And parents are thrilled when you're collaborating with the other professional in the child's life. A long time ago, I made this worksheet called Establishing Successful Professional Collaboration. And I keep this in a child's file, and it just reminds me that other people are working with the child. I have their contact information. I have the best time of day that they can be reached, or their method of communication that's preferred. Because oftentimes, because collaboration doesn't have a deadline, it falls to the bottom of my to-do list, which is unfortunate. So I really try to keep it present in my mind that other people are working with my child, and try to reach out and collaborate as much as possible. Okay, so we flew through treatment of apraxia. It's hard to put it in an hour and 30 minutes, but I hope you guys will leave feeling like you got something from this. And from me to you, this is a little encouragement. Who doesn't like a witty pun? But I'd like to open up the floor to some questions if I can help. So I think we're going to do that now.
Absolutely. All right. So first, it looks like the link to the questionnaire isn't working anymore. So I don't know if you have maybe an updated link. maybe we can just send that to my email and I can post it on our social media page later on.
Absolutely, absolutely.
If possible. All right, so everybody look out for that on our Facebook, Instagram, social media pages. I'll get that out as soon as we can figure that link out for y'all. Another question, do you have a chart of visuals to go with each sound?
So I don't. I, over time, have created my own visuals to go with the sounds that I'm teaching, but I know there are some commercial products that have them. One of my absolute most favorite SLPs and mentors is Pam Marshalla. Therapro has a lot of her products, but Pam is no longer with us, but in some of her books, she has cues for the sounds that we teach. So I would definitely look to her as a resource. And there are some other commercial products, but if you can use a visual cue that demonstrates place and helps child get into the correct position, that's what we're looking for. But there are some commercial cues out there for you to look at.
Great. Another question. How young can a child be diagnosed with CAS? My daughter is 17 months old and has no words and very few sounds. She has gross motor difficulties and is delayed. She has trouble with motor planning. We are thinking she may also have CAS. Can treatment begin this young?
So a child has to have enough verbal output for the speech pathologist to analyze. So it doesn't really go with an exact age. So you need a certain amount of output. What we need to do as speech pathologists is we need to assess what happens to a child's speech when they try. And so when they have enough where we get to see them try things that are, that start to increase in complexity, that's where we can really give them a definitive diagnosis of CAS.
All right. What visual prompting program are you using?
um, it's just one that I've been using forever that I kind of created over my 20 years of practice. So it's always the same, and it's the same throughout with all my kids. But like I mentioned before, they're just cues that are related to the sound and place and manner that I have created that seem to really help the kids.
Awesome. How are you prompting children with low language or cognitive skills, for example, ASD?
So I often will bring in AAC for this type of kiddo. It's likely that there are language needs as well, so I wouldn't ignore language and certainly set the child up for a more holistic way of treatment. AAC would be imperative for a child with, especially a young child with ASD.
Okay, do you have any suggestions for co-treatment with OTs and speech for individual sessions or as a group session between the two?
You know, I wish I've had the opportunity to co-treat, but I never have. So I don't have a great answer for this question because I've never done it. But I would recommend if the speech pathologist can provide the targets that she or he is working on to the OT, and the OT could try to weave them into her therapy, that would be ideal. That's something that I definitely do quite often. In fact, I do that with more than just OT, but maybe ABA. And that might be a good answer to the ASD question as well. Sharing targets with someone who's providing ABA services to a child with ASD is also a great way to collaborate.
Great, and then a question about billing. What code do you feel is best to use when billing insurance companies?
I would only recommend using the code that fits the child. So there is a code for apraxia that you can use. If they have other diagnoses besides apraxia, you can certainly use those as well. But yes, only obviously the code that the child is diagnosed with.
Great, it looks like that's all the questions. We have a couple of comments. I love you is from Brazil, and thank you for your time and those lovely comments that are always nice to see. So